My name is Alina Gonzalez Mayo, and I'll be going over the anxiety disorders with you. One change that occurred in DSM-5 from DSM-4 is that anxiety disorder chapters no longer includes OCD or Obsessive-Compulsive Disorder, PTSD or Post-Traumatic Stress Disorder, and Acute Stress Disorder. The OCD, what was done is that they removed it from anxiety and put it in a separate chapter on obsessive compulsive and related disorders. The PTSD disorders are now in the newly formed trauma and stress-related disorders. This is all fine and good, but understand you really do not need to know these things for the exam. The disorders will still be the same. Where they are in the DSM-5 will not be important. When we think of anxiety, we have to understand that it's nothing more than a syndrome. It's a syndrome where you have both psychological components as well as physiological components. The psychological components of anxiety are the apprehension, fear, or worry, the fact that you believe that something terrible is about to happen. Patients will also have problems with concentration and be hypervigilant. The physiological components are the signs and symptoms of autonomic hyperactivity like shortness of breath, sweating, palpitation, tremors, etc. There are various theories as to why we have anxiety. In the psychodynamic theory, Freud believed that anxiety disorders occurred when you did not let the id do what it wanted to do. You will never see this on an exam. As far as the behavioral theory is concerned, we always know that a lot of these disorders related to anxiety tend to be learned, and this is clearly evident in the patients who have phobias. So you're a child, you get bitten by a little animal. Now as an adult, you can be afraid of all animals. And the biological theories deals with the neurotransmitters, mostly involving norepinephrine, serotonin, and GABA. That is why the treatment of most of the anxiety disorders will be the antidepressants, which focus on the norepinephrine and serotonin, and the benzodiazepines, which focus on GABA. Let's begin with one of the anxiety disorders, which is panic disorders. And for you to have panic disorders, you need to have panic attacks. Panic attacks tend to be very short-lived. You're going to have intense anxiety, usually lasting anywhere from 5, 10, 15, 20 minutes. The anxiety is so intense that you feel that you're going to die. You feel like something horrible is going to happen. Now, the physical symptoms you typically find in these attacks will be the shortness of breath, the diaphoresis, the palpitations, tremors, quivering voice, etc. You need to have these attacks for at least 1 month, and you're going to be worrying about these attacks, and you're going to change your lifestyle because of these attacks. In DSM-4, panic was diagnosed with or without agoraphobia. However, this was removed in DSM-5. Some risk factors associated with panic disorder could be history of childhood separations, child who is not seeing the parent, that increases anxiety. You could have losses as an adult. They think that it is genetic, so you tend to see greater incidence in the twins, especially monozygotic twins. And what they've also found is that patients who have panic disorders should stay away or avoid certain items which are called panicogens. These include sodium lactate, CO2, yohimbine, caffeine, epinephrine, etc. Alcohol, for example, can be a panicogen. Many patients who have anxiety disorder drink because they think it's going to make them feel better when actually it makes them feel worse. Panic disorders affect about 2% of the population, and you tend to see it more frequently in women than in men. Typically it occurs during the early 20s, and as is true with most disorders, you have good times and you have bad times, so symptoms do wax and wane depending on the current stressful situation. However, the hallmark of a panic attack is that it typically occurs out of the blue. There's no specific stressor. You could be reading a book, you could be watching TV, you could be on vacation when all of a sudden these attacks begin. So reviewing again the clinical presentation of a panic, Like I mentioned earlier, it's going to last several minutes. It can be associated with depression or drug abuse or just anxiety overall. Agoraphobia is a fear or avoidance of places from which escape would be difficult in the event of a panic attack. So these are patients who traditionally would stay indoors because they're afraid of going out, and then where would they escape to should they have a panic attack? So they feel safer at home. They know where their phone is, their meds are, etc. You tend to see women have more agoraphobia than men. In DSM-4, where panic was associated with or without agoraphobia, what DSM-5 did is that it classified it as a separate anxiety disorder. For the treatment of panic disorder or panic attack, it's very important that you identify which one of the two is occurring in the patient. The panic attack, the patients will be in the attack at that moment. So their heart rate will be elevated, their blood pressure will be elevated, their respiratory rate will be elevated. And the best way to treat that is to give them a drug that works immediately. So when you're looking at benzos versus antidepressants, benzodiazepines are more indicated. Benzodiazepines are given to these patients, and within seconds or a few minutes, the patients start to feel better. Any benzo can be used for this treatment. Alprazolam can be given, clonazepam can be given, lorazepam can be given. So any one of those three are definitely viable options. However, for the treatment of panic disorder, we're assuming that this is an ongoing problem where the patient has been having panic attacks for more than a month. So what we need to do is give them something or a medication that's long-lasting. That's where the antidepressants come in. So chances are they will give you an SSRI or a serotonin selective reuptake inhibitor. These include fluoxetine, which is Prozac, sertraline, which is Zoloft, paroxetine, which is Paxil, fluvoxamine, which is Luvox, citalopram, which is Celexa, and escitalopram, which is Lexapro. Because we're dealing with neurotransmitters of norepinephrine and serotonin, the SNRIs can also be used, such as venlafaxine, which is Effexor, desvenlafaxine, which is Pristiq, or even duloxetine, which is Cymbalta. MAO inhibitors, as well as tricyclic antidepressants, are also used. However, if we focus on the side effect profile, SSRIs are clearly the way to go because they're cleaner, patients are more likely to take them. So chances are they will give you either sertraline, paroxetine, or fluoxetine as one of your choices. They will not give you two, but they'll give you one, and that's the one that you would have to pick. As is true for all anxiety disorders, since some parts of anxiety are learned, then maybe relaxation techniques can be helpful. Certain patients can know when panic attacks will strike, so that's the time when they start having deep breathing exercises or guided imagery, etc. Systematic desensitization can also be used to treat the agoraphobic symptoms. Now let's review phobias. Phobias are irrational fears of either objects or situations. So here we have individuals who are afraid of certain things, and the things that they're afraid of are really irrational. And not only are they afraid, but they do everything humanly possible to avoid that one thing that they're afraid of. There tend to be two types of phobia: specific phobia and social phobia. The specific phobia is that individual that's afraid of a thing. For example, heights, animals, water, baseball bats, whatever. And you do everything humanly possible to avoid that specific object. What is unique about DSM-5 is that now they have a duration requirement where you have to have these symptoms for at least 6 months. And it will be applying to all ages. Social phobias, which now are called social anxiety disorders, are those individuals who are afraid of certain situations. Now, these typically are situations where something potentially embarrassing or humiliating can occur, such as using a public restroom, speaking in public, or even eating in public. So these are individuals who probably prefer to stay home and they don't go out because they're afraid of being embarrassed or humiliated. When looking at the treatment of phobias, you have to be very clear as to what type of phobia it is that we're treating. Since specific phobias, we are to assume that they were learned. We're not born being afraid of water or heights. We learned it. Something happened to us maybe in our childhood, and we associate whatever happened to us with those phobic objects. So if we learned it, then obviously we can unlearn it. So the treatment of choice for specific phobias will be something involving unlearning these behaviors. You can use techniques such as systematic desensitization, exposure, flooding, etc. Systematic desensitization is based on the premise that anxiety and relaxation cannot occur at the same time. So what you are trying to do is to replace one for the other. So you're going to come up with a list of something that gives you anxiety, and you're going to go from the least anxious to the most anxious. You're going to start doing the things on your list, and as you go from one to the other, you will start doing relaxation techniques as well. Flooding is a massive exposure. If you are treating social anxiety disorder or social phobias, then the treatment of choice will be pharmacotherapy. And again, the SSRIs will be the treatment of choice. I doubt very much that they would give you 2 SSRIs. You're going to pick one, and that's the answer. They might make you pick between an SSRI and a TCA, or an SSRI and an MAOI. Because of the side effect profile, SSRIs are the go-to drugs. Beta blockers are only used in patients who have stage fright or performance anxiety. These are patients who have no difficulties functioning. However, they're afraid to speak in public, for example. So what happens when you're afraid to speak in public? Your hands shake. What you tell the patients to do is that you take a beta blocker, something like propranolol, half an hour to an hour before the event. And what that tends to do is that it tends to mask the external autonomic hyperactivity, therefore making you calmer. So let's review. For specific phobias, behavioral modification is a treatment. For social phobia, SSRIs will be the treatment. And for stage fright / performance anxiety, beta blockers will be the treatment of choice. Generalized anxiety disorder, or GAD, is an individual who has a lot of anxiety about basic life circumstances. However, what's unique about this disorder is that you need to have these symptoms for more than 6 months. Not only do you have these symptoms of anxiety, but you also have problems with irritability, problems with sleep, and concentration. The hallmark of the patients who have generalized anxiety disorder is that they worry about things they truly don't have to worry about. They worry about losing their house, although their house is secure. They worry about their job, although their job is secure. It tends to be genetic, as is true for most of the anxiety disorders, and you tend to see it more frequently in women than you do in men. Generalized anxiety disorder, or GAD, affects about 5% of the population, more common in women and men, typically starts in childhood, but it tends to occur later, and it can be associated with depression and even substance abuse. In the treatment of generalized anxiety disorder, as is true for most anxiety disorders, you're going to have 2 basic options: psychotherapy, or behavioral mod therapy, I should say, versus pharmacotherapy. Pharmacotherapy will either involve the use of buspirone or an SSRI. Buspirone is an anti-anxiety agent that they believe works on serotonin. Since both are indicated, I do not expect both of them to be on the exam. The behavioral mod that would probably be indicated in these disorders would be relaxation training and possibly biofeedback. But again, most times the treatment of choice for generalized anxiety disorder that you will see on the exam involves medication. So pick either buspirone or an SSRI. Obsessive-compulsive and related disorders, as mentioned earlier, got removed from the anxiety disorder chapter in DSM-4, and it got put into a separate section. We have included it in the anxiety disorder chapter, since that is where most of us are used to seeing it. However, the disorders still remain the same even though it got moved in DSM-5. In this chapter, you will find Obsessive-Compulsive Disorder, Body Dysmorphic Disorder, which used to be a somatoform disorder. You also have trichotillomania, which used to be an impulse control disorder, excoriation or skin picking disorder, substance medication-induced obsessive-compulsive and related disorders, and obsessive-compulsive and related disorders due to another medical condition. We will be focusing on obsessive-compulsive disorder, so let's begin. For patients to have obsessive-compulsive disorders, you either have to have obsessions alone or compulsions alone, or typically what is found in most cases, both obsessions and compulsions. An obsession is nothing more than a thought which is repetitive, intrusive, and senseless. Having thoughts all day that you can't control will increase your level of anxiety. The brain fixes this by creating a compulsion, which is an act, which will neutralize the thought. Now, these acts are repetitive and time-consuming, so if you think you've gotten dirty, you wash your hands. If you think you left the stove on, you turn it off. So the obsessions increase your level of anxiety, but the compulsions will reduce it. What's unique about the patients who have OCD is that they have what is called ego dystonic symptoms. They're not happy with the fact that they have these symptoms and they cannot control it. What they have added on DSM-5 is specifiers, where now the patient will either have good or fair insight or absent insight with delusional beliefs. I cannot imagine that this will be asked on the exam, so let's focus on obsessive-compulsive disorder, how to identify it, and how to treat it. The theory of OCD or obsessive-compulsive disorder is that patients have problems in the serotonin metabolism. They do believe it's genetic. It affects about 2% of the population. However, you have equal incidence in men and women. These symptoms typically start early on, and as is true for most disorders, they tend to wax and wane. In periods where you have a lot of stress, the symptoms worsen. In periods where you have less stress, then the symptoms tend to get better. Because of the severity of the symptoms, you would expect patients to also get depressed and possibly abuse alcohol or drugs in order to either control the symptoms or make themselves feel better. The treatment of choice for obsessive-compulsive disorder will either be behavioral modification or pharmacotherapy, or the combination of the two. If we focus on pharmacotherapy, since OCD is linked to serotonin, we will choose drugs that work on serotonin, and these include the SSRIs, SNRIs, TCAs, etc. However, on the exam, chances are an SSRI will be there. So you would pick drugs like sertraline or paroxetine or fluoxetine or even fluvoxamine. One of them will be there, that's what you pick. Behavioral therapies could include something like exposure and response prevention. So they expose you to your obsession and then they don't let you perform the compulsion. I do not expect them to give you both and make you pick one. So one or the other will be there. My bet, however, is that they will be asking more pharmacotherapy than anything else. You're going to treat these patients for at least 6 months or more. Let's focus now on PTSD and ASD, which used to be in the anxiety disorder chapter in DSM-4 and now is in the chapter called Trauma and Stress-Related Disorders. As you can see, there are many disorders in this chapter, but we will only be focusing on post-traumatic stress disorder or PTSD and acute stress disorder or ASD for now. The patients who have acute and post-traumatic stress disorders are individuals who's been exposed to a stressor. Now, this stressor is a stressor that's usually stressful for anyone. It's a stressor where you think your life is in danger or you've witnessed something horrible. For example, earthquakes, floods, war, rape, etc. If the symptoms last less than 1 month, the diagnosis is acute stress disorder. But if the symptoms last more than 1 month, then the diagnosis becomes post-traumatic stress disorder. So it's very important that you focus on the duration of the symptoms in order to answer these questions correctly. You should note that if no time is mentioned, then post-traumatic stress disorder becomes the better answer. These symptoms can occur at any age. They usually occur, however, immediately after trauma, but some of them may take months or years to develop. Usually, about half of them will resolve within 3 months. For you to be diagnosed with these disorders, you need several symptoms. One of the most important ones is the re-experiencing of the stressor. So at night, you'll be having nightmares related to the stressor. So if you survived a rape, your dreams will be rape-related. You're going to have flashbacks, which are vivid recollections which are occurring during the day. So for a brief moment, you might feel or believe you are being raped again. You're going to exhibit certain avoidant behavior, so you will avoid anything that reminds you of the original event, and this is something called phobic avoidance. You're going to have alterations in cognition and mood, so you can be irritable, angry, depressed, anxious, etc. And you will be very hypervigilant and have an increased startle reflex. So you're in hyperarousal. You scare easily. You're constantly scanning around the room. If you were raped, you're making sure that your door is locked. You make sure that your house is safe. For the specific diagnoses of acute stress disorder, as is true for PTSD, the traumatic events may be experienced directly, witnessed, or experienced indirectly. You're also going to have certain mood symptoms, such as negative moods, dissociative symptoms where you feel you're not real, avoidance symptoms, and arousal symptoms. However, these symptoms will last more than 3 days up to 1 month after being exposed to the traumatic event. So time is of the essence if you're going to make the diagnoses of acute stress disorder. Other interesting features that you find in these disorders is a concept called survivor guilt, which tends to be very irrational. If you're at war and everyone in your troop dies except you, then you feel guilty about that. You feel you should have died as well. You feel that you could have done something for them, and you carry that guilt with you throughout. The treatment of this will be therapy, survivors group therapy, and if you choose to use pharmacotherapy, typically antidepressants will be used. And again, focusing on the ones that have the least amount of side effects, so the SSRIs, even the SNRIs can be used. Although benzos can be used, you tend to avoid them in the active stage of therapy, where one of the treatments will be prolonged exposure. And the goal of prolonged exposure is that you are constantly reliving the stressful situation in order to become desensitized. And you need to do it by yourself, not with the use of a benzodiazepine. Now, prazosin has been found to be helpful in patients who have nightmares. So you start the dose in the HS or nighttime and increase it accordingly. However, the treatment of choice, if we're talking about meds, will be the antidepressants.